And I think some of you may have also been in the presentation that was the case-based studies that Erica led with Dr. Safer. That was an amazing presentation. I just want to say I found it really, really helpful to go through some of the kind of more nuanced problems that you may run into with hormone therapy. Does everybody here in the room prescribe hormones? And is everybody familiar with kind of the basics of hormone therapy? So because when I submitted this presentation, I wasn't entirely sure what my audience was going to be. So I may be skipping through a lot of these, but they're all available to you if you have questions about some of the more basic items about hormone therapy. So I was lucky enough to attend the WPATH Symposium in Montreal in September, and Dr. Rachel Levine was the plenary speaker, and she had a very clear message, which is that gender-affirming care is suicide prevention. So, we talk about doing no harm. I want to point out that the harm that we do is by omitting gender-affirming care. Unfortunately, we were just reading about a new right-leaning conservative group called Do No Harm that is led by sounds like a nephrologist, previously a dean of a medical school, and they've co-opted that term to basically send the message that providing gender-affirming care is causing harm, and that's just not true. And it's not borne out in the evidence. So just be aware of that political environment that's out of there, that's coming out. That group is responsible for a lot of the news bills that are going towards state legislatures that are trying to ban gender-affirming care for adolescents. This topic I feel comes up a lot when I'm talking to my colleagues who maybe are new at providing transgender care. And this maybe is one of the number one concerns we have as physicians, that we worry about people having regret. The actual regret rate is exceedingly low. I think there was a most recent article in the last few months that quoted a number of less than 1% of patients who have gender-affirming surgery or any changes related to their gender-affirming care that regret it. And of those people that do regret it, the vast majority regret it because it's really hard in our community to be transgender. They've had a lot of family pressures, social pressures, work pressures, et cetera, that have made it hard.
Slides that only people can't see you.
Oh, okay.
So you can keep talking and we'll switch.
Gotcha. All right. Sorry, here you go. So I just want to point out that the regret rate is actually exceedingly low. In fact, the regret rate for things like knee surgery is much higher, and for elective cosmetic surgery is much, much higher. So I really try and allay that fear when I talk to my colleagues about making sure they include this type of care in their practice. Glad it's not just me.
There's
The trials of the hybrid conference, I'm afraid, folks.
That's the one. Yeah, perfect.
Okay.
Awesome.
Should be good to go.
Thank you very much.
You're welcome.
So I have this slide on here because I think in the general public, gender affirming care encapsulates everything related to hormones and puberty blockers, and I worry a little bit that term is a little bit too all encompassing when it comes to all of these state legislature bills that are coming up that are anti-trans. And I think you know, we just need to keep in mind that gender affirming care is not just all about hormones. It's not about surgeries. It's about how you interact with your patient in your exam room. So it's more about honoring pronouns and honoring names and asking your patient about their lived experience, and not so much you know, focusing on hormones and surgery. So I think that even if you don't prescribe hormones or you don't perform these surgeries, you still can provide gender affirming care by acknowledging the differences in your patients. So if you care for adolescents, and a lot of us are family doctors, so we have lots of adolescents in our practice, I may not be the one to prescribe the puberty blocker, but I provide gender affirming care to my adolescents. So I make sure I know what their pronouns are. I interview them separately away from parents so that I can understand what their gender issues might be. So just keep in mind, it's not always about hormones and it's not always about surgery. And I think the public may kind of forget that aspect of care may be getting lumped in with all of the discussion about puberty blockers and hormones, and that worries me. So I'm going to skip over these particular slides because I think we're in a group that maybe is feeling comfortable in this arena. And I think what I'd like to focus on is a bit more of the primary care aspects of caring for patients who have undergone gender affirming surgery, just because I think we're going to see it more often in the primary care environment. And I really feel like we ought to be very comfortable with managing this. So let me just skip through these. All right. So I think, you know, when you have patients who identify as transgender or gender diverse or non-binary, it's tempting to kind of forget about all the rest of their care. So I think as primary care providers, we should have that at the forefront, that they still have bodies that need to be taken care of, that they have many other issues besides just their gender that actually need attention. So particularly for those of us that have kind of, you know, by default moved into this sort of, you know, specialty of primary care, you know, it's tempting to want to just focus on managing hormones, but I just want to remind you that this is a really good opportunity to provide really comprehensive care for your patients. One of the things I teach my residents from the get-go is the concept of an organ inventory. And what this does is just set the stage for understanding what parts your patient owns so that you can tailor the preventive care that you're providing for your patient. So as part of a new patient visit, I actually will go through the SOGI page. Fortunately, Epic, which is our EMR, does a really good job of capturing that information on the page. So the patient and I fill that out together. So that we do have a good understanding of exactly which organs are owned by that person. So what about pap smears? And really glad Marie's here. So we have a gynecologist in the room who also does gender affirming care. And this was something I had to navigate as a new resident and then faculty to manage. How do you manage pap smears? I mean, this is kind of a fraught space for our trans men. There's a lot of dysphoria around this. And you know, they have cervixes, they have uteruses in most cases. So how do you know, what do you do? And what I did not really appreciate fully when I first started this work was that when a person is on testosterone therapy, you essentially have, after several months to years, especially on chronic testosterone therapy, a postmenopausal genital area. So, so this means that it's not going to look the same as you might expect for somebody of reproductive age. So frequently, one of the pitfalls is an inadequate sample, which often happens with postmenopausal cisgender women, where you just don't have the turnover of those epithelial cells because there's an absence of estrogen. This is all common in our trans men that have been on testosterone. So things like vaginal stenosis, dryness, and discomfort can occur, especially with this exam. So how do you treat this? So I recommend to my patients that we pre-treat them with transvaginal estradiol. And this is to help just promote the overturn of epithelial cells inside the vaginal walls. It will help lubricate, it will make the vaginal walls a little bit more compliant, and the test with the speculum a little bit more comfortable to take. And I, in reading the literature, I've seen anywhere from 2 weeks to 6 weeks of topical estradiol cream to be used prior to the exam. You can use a pediatric speculum. This just provides a smaller speculum, understanding that stenosis may be an issue, so that you are able to still visualize the cervix. And obviously a trauma-informed approach. I'm really sensitive to the fact that for a lot of trans men, they've not had good experiences when it comes to gynecologic or preventive care with their physicians. So this is a time where I let the patient tell me at each step of the way if they want to continue, and that they have full control over what is happening during the exam. And at any time, they can stop the exam and decide we're not going to do it. So that's always something that's an option, is just to skip it entirely. There's some good work being done around just doing a self-collected high-risk HPV swab. And I think this is going to be sort of the wave of the future, to take a look at, presence of those high-risk HPV strains. I think we will have better adherence to being able to actually test for HPV when this becomes more common practice. So contraception is something I talk with all of my patients about, regardless of whether they're cisgender, transgender, non-binary. I think it's appropriate to always have a discussion about reproduction in primary care. For trans men, testosterone is an imperfect contraceptive, and it's a teratogen. So pregnancy is contraindicated with testosterone and may occur. And the most common likelihood is missed doses of T. So if the dose is missed, they may have menses, they may have an ovulation, and may have the potential for a pregnancy if they have intercourse with a penis that makes semen. So we talk in that plain language, so that there is an understanding of when pregnancy might occur. So vaginal bleeding. So in trans men with a uterus, typically under 6 months of therapeutic T, so good therapeutic range, their menses should generally stop. There are still some people who may continue to bleed, but after 6 months, if that bleeding is continuing, then I would work them up as abnormal uterine bleeding and go down that same pathway to look at structural, hormonal, et cetera, problems that are causing the bleeding. So what about breast cancer screening in trans men that still have their breasts? So the guidelines are still the same as for cisgender women. For those trans men that have had mastectomy with nipple graft, there is still some residual tissue left behind. It's not similar to like a radical mastectomy that might be done for cancer removal. So technically there is a possibility of breast cancer occurring. There's really no specific guidelines for post-mastectomy trans men, but this is where I would go by clinical management. So if there's any abnormality felt, any lumps, bumps, skin changes, anything, obviously that deserves a diagnostic workup, but screening recommendations don't exist right now. What about trans women with breasts? So similar to cisgender women, the incidence is likely low, but it's not zero. And it may increase with the length of time on estrogen. And I was just reading this morning that the incidence of breast cancer for trans women is likely about the same as cisgender men. So mammography screening is really not a great tool. However, I have this discussion with my patients, and we do a shared decision making on the benefits of mammography, the limits of that screening, and their feelings around it. Some of my patients have found it very affirming to go in and get their boobs squished, just like the rest of us. So I think it's just fine to do it, as long as they understand there may be additional imaging that's needed for really good pictures. So what about prostate cancer screening in trans women? So if a patient has had their vaginoplasty or vulvoplasty, the prostate is preserved. Now it shrinks down to almost nothing under the influence of estradiol. It is located anterior to the vagina, so rectal exam is no longer useful for examining the prostate. And given the anatomy of the interior of the vagina, which, and we'll go through that in a little bit, it will be pretty much impossible to palpate. Even if you were to palpate the anterior vaginal wall, you're likely not going to feel anything meaningful. So that said, the guidelines for cisgender men, we go by the U.S. Preventive Services Task Force for prostate screening. This is another shared decision that I do with my patients. A lot of them don't enjoy talking about their prostate. So it can be a little bit of a tough conversation to navigate. And ultimately we come to a shared decision about doing prostate cancer screening. The incidence for prostate cancer is probably low for trans women, but again, it's not zero. So let's talk about vaginoplasty in primary care. So this is vaginoplasty is the creation of a new vagina, typically done with the penile inversion technique. There's also a vulvoplasty, which does not include the construction of a vagina, but does include the external construction of a vulva. So a little bit different between the two surgeries, and it's a patient-oriented decision about what they decide to go for. So we're mostly going to be talking about the penile inversion vaginoplasty, so creation of a new vagina. And I wanted to talk about some of the things we can manage as primary care physicians in the office for some of the complications or side effects that may happen, in the days to weeks to months after surgery. So stuff we can do in the office, we can help them prepare. I think some of my trans patients that are pursuing surgery were not aware of needing to do all hair removal. So this is something we broach early on because it can take a good 6 to 12 months to remove the genital area of all hair. We optimize any chronic health conditions. I had a patient who had type 2 diabetes that was not well controlled. So that was one of the things that we worked on before she was ready for her surgery. They will need a referral for their 1 letter or 2, depending on what their insurance is doing, because insurance hasn't caught up yet. And then it's helpful if you have paperwork from the surgeon, or you can speak directly with the surgeon to find out what their particular requirements are. In Nevada, we only have 1 gender affirming surgeon who's in Las Vegas. I have him on speed dial, so I'm able to talk to him fairly readily. So it's nice to be able to communicate that easily. But for the most part, surgeons will request that they've been on gender affirming hormone therapy for a year and have lived in their outwardly in their gender identity. It's interesting. the 1 year continuously living in the gender identity, I find that kind of interesting, because sometimes it may not be safe for people to live in that gender identity before they have their feminizing surgeries. So I'm not sure that that is valid. But again, some insurances may require that. So you may not have much of a choice. Smoking cessation is huge. So that would be a #1 priority in patients that are using tobacco. I will help them to stop, because surgeons are just not going to be comfortable operating on somebody who continues to smoke, because it really affects wound healing. So I have some photos ahead. This is from one of my patients who gave me her full and express permission to use her pictures. This was her post-op day 1 picture after a vaginoplasty. And as you can see, fully in place because of the reconstructed urethra. This is post-op day 7. On her right side, she is actually in the process of losing one of the labia. So she did have necrosis of one of the labia that occurred, which can happen. She's a somewhat older patient in her 60s and does have type 2 diabetes. This is post-op day 35. And you can see there's still a little bit of persistent granulation tissue, but she's having good healing elsewhere. So it still has that kind of raw look to it, and that's all normal. It's all normal. So this is why she wanted to share these pictures, because she wanted everybody to understand what looks normal, so that when you see it, you can modulate your own reactions to things. But this is all considered normal healing after vaginoplasty. This is post-op day 42. She came in for an office visit, and we did treat a couple of persistent granulation areas with a little bit of silver nitrate. And then lastly, this is not her. This is a picture from Dr. Bowers's website. This is a longer post-op patient. So generally has a very indistinguishable appearance. So as you can see, this is when an organ inventory is really helpful, right? Because you can't necessarily predict based on an external appearance what's on in your patient. So for the first few weeks, the surgeon is going to handle most of any significant postoperative issues. But what can we do in the office? So minor superficial tissue infections. So this is basic surgical care with no abscess. A course of antibiotics is reasonable. For granulation tissue of the vulva, it can be treated with silver nitrate. If there's vaginal granulation, so granulation on the inside of the vagina, there may be specific surgeon preferences. This might be where you pick up the phone, talk to the surgeon, and say, "Hey, how would you like me to treat this?" You can use intravaginal low-dose corticosteroids or even meta-honey paste that's applied to a dilator, and this can help heal the granulation tissues. These granulations can sometimes present with just persistent bloody discharge with dilation. So what about vaginal discharge? So this I think for me was a big point of learning, because I was like, what does the discharge look like? What is normal discharge for somebody who's had a vaginoplasty? If the vaginal discharge is persistent and odorous, generally this is retained foreign material. So maybe lubricant left behind from dilation or semen left behind after intercourse. The vagina that's constructed is made of skin. So it's not the same kind of mucous membrane like a cisgender vagina, right? So not self-lubricating, not as renewing as a vaginal epithelium is. So in this case, because because it's not self-cleaning, the patient actually needs to do some self-cleaning, which is by douche. So douching is done with water and vinegar, or you can use water and iodine soap, and then soap and water douching. So, you know, a common question is, well, would this be bacterial vaginosis if they have kind of chronic discharge? And the thing to remember is that this is skin, it's not vaginal epithelium. So the bacterial flora is going to be much different. The pH is different, the environment is different. So it's extremely unlikely to be bacterial vaginosis. And there's, we were looking at our transgynecology book, and they talk a little bit about this. And lactobacillus is not one of the prevalent bacteria in this environment. Yes. Yeah, good question. Yeah, the question was, how do you do a speculum exam for these patients? And an anoscope works very well. Depending on how stenosed or how small the introitus is, kind of depends on each patient. You could use a pediatric speculum, you could use an anoscope, you could use a regular size speculum. So they start dilating immediately after surgery. So it is okay to put something in there. Yeah, the initial dilators are going to be very small. And there's like a whole dilation protocol. They start with small dilators, 10 minutes, 3 times a day with a small dilator, and they very slowly work their way up to a larger dilator. So yeah, it is okay to look. And I will tell you that if you do a manual exam, it feels a lot different because, we're so used to the pubic bone being round for cisgender women. The pubic bone is going to be very different. So when you put your 2 fingers in, you're going to feel that resistance there, and that's normal. All right. I think a hard part for patients undergoing this surgery is to manage dilation. It's a big commitment in time. And for a lot of patients, it is the reason why they ultimately will have issues with stenosis, is because dilation is hard. With my patient, we're very good friends. We actually got into a little texting thing because I was trying to encourage her with her dilation because she was starting to fall off. So I would text her a eggplant and then she would text me back a cigarette. So it was just a way to help promote dilation. So whatever method you find helpful and encouraging for your patient to do that, because it is so important. Spraying of urine is really common for the first several weeks. The urethra has been rerouted and also shortened. So spraying of urine is very common. That will resolve over time. UTIs do happen because of that shortening of the urethra. This is common, and they should receive a longer course of antibiotics. And then because they haven't necessarily been taught this, they need to be taught to wipe from front to back. This is a common complaint I've heard in my trans women, is that they feel this heaviness and pressure that is really uncomfortable, and they feel it's worrisome for them. Feels like their innards are falling out. If any of you have had a baby, it's kind of that feeling of, like if you push too hard, everything's gonna come out. And that feeling of heaviness and pressure is completely normal, and usually signals that they've been up on their feet too long and they need to just sit back and rest. Let's see, for post-op masculinization care, this is essentially just straight wound care. This to me is not terribly complicated. Probably the worst complication I've seen is just keloids, and those are easily managed in primary care with interlesional steroids. Works great. And then the other issue is called dog ears. So that's when the sort of, where back fat is Sometimes you can get little sort of puckering and an overlay of skin over to the sides, and then those are usually warned about by the surgeon and can be dealt with in a follow-up surgery. Things that need the surgeon include just development of big seromas, asymmetrical swelling, or nipple necrosis. So I've only got 5 minutes left. For Meta, there's not a lot we would do in primary care for this particular surgery. This is just a releasing of the clitoris from its surrounding ligaments so that it may fall more forward in a more masculine way. Phalloplasty, I do have a couple of patients that are in the midst of these staged procedures. These are not available in every state. In fact, my patients have had to travel to the East Coast to have this done. So I do not have a lot of experience with post-op phalloplasty management. So I would say this is complications of phalloplasty I'm going to be handing over to the surgeon. I included here a little bit about adolescents. This is a fantastic website, jackturbin.com. He is an assistant professor of child and adolescent psychiatry and has curated a list of references that show us how beneficial gender affirming care is for adolescents. And I've included those references in here. I wanted to address rapid onset gender dysphoria. I had one of our staff psychologists ask me about this term. It is not a thing. It was based on a single very flawed study that has since been corrected, and there is no such thing. So I just want to stress again that gender affirming care is suicide prevention. I don't think that Zoe in the Montana legislature was wrong when she claimed that the legislature was going to have blood on their hands. These kids are going to die. I added here resources for us. There's many in here. And I also just bought the book Trans Gynecology, which just came out a few months ago. It is fantastic. Really great book. And I have a copy of it here if you want to take a look. I wanted to very quickly go over unhelpful resources. There's a whole lot of them out there and they're growing. These are the places you want to avoid. So a lot of these have a veneer of scientific respectability, but they are not. SEGM is the one that Florida legislature has been using to back up their bills. This is a conservative website that is anti-trans, anti-LGBT, anti-everything. The American College of Pediatricians is a hate group. So if you see, if you try on a university website to go into the ACP's website, mine blocks it because it's a hate website. So American College of Pediatricians is not helpful. There's a whole bunch of other ones here. There's others that I think there's the Alliance of Defending Freedom is another one that has an anti-trans agenda. And as we just heard about, the Do No Harm group that is led, unfortunately, by a physician is now at the root of a lot of these bills coming to the legislature. Questions? Anything I missed?
So we have some questions from the chat, if you don't mind me bringing those up. The first one is, what language do you use when doing an organ inventory to avoid contributing to feelings of dysphoria?
So that's a really great question. I have elected to fall back onto the SOGI page that is in my EMR with Epic that is anatomical terms. The reason I trust that is because I know the person that helped build that page is from the trans community. So I feel that it is as best as I can do to make sure that the dysphoria is kept to a minimum. We also read it. I don't necessarily say the words. I will point and say, does this describe you? And then they can make some check boxes. So it's really hard sometimes to get around with, anatomical terms without triggering dysphoria. You can always ask the patient what terms they prefer to use, and that's fine too.
Excellent, thank you. Switching gears, this next question is, how does some of the post-op vaginoplasty care differ in patients who have the peritoneal pull-through technique?
So that's a good question. I am not in my region, that is not practiced. So that particular method is one of the sort of secondary procedures. The most common one done here in the US is the penile inversion technique. So we don't have as much experience with the peritoneal pull down. I will say with the peritoneal pull down, you're going to have a different interior tissue that is going to make mucus, and will have it because it's a different type of tissue. So it will have a different environment than the penile inversion technique.
The only thing I would add to that is that because it is colonic tissue, you can let the patient know that at the time of their colonoscopy, it might be a good idea to have the gastroenterologist who's performing the colonoscopy to also take a look at that tissue, because it can grow polyps. So, and not something that you're necessarily going to be looking for if you're using an endoscope or something like that.
Yes.
How painful was like on post-op day 35 with all that granulation tissue? Is that painful, sensitive? It really was.
So the question is, how painful or sensitive is that granulation tissue at post-op day 35? Not terribly. At that point, she was still using a peri bottle to cleanse after voiding. So not, I mean, she was back to work at that point, doing quite well. Yes.
Kegel's helpful in transgender.
So the question was, are Kegels helpful? And I would say that pelvic floor physical therapy should actually be part of standard post-op care for patients having vaginoplasty, because there can be a lot of issue with muscle spasm, particularly with dilation. So really great question, but pelvic floor physical therapy is super helpful.
We have another question from the chat here. This is in regards to post-op vaginoplasty. Is there any utility in checking for BV or Candida then? How would you do testing to see what could be causing the infection / odor?
So BV is unlikely because of the fact that it's a skin epithelium. Candida is also less likely. It's not impossible, but it's not a typical environment for Candida. If there's concern for any kind of sexually transmitted infection, then you would test similarly that you would for a cisgender person.
And I believe that's all from the chat questions for now.
Yes.
What kind of concerns are there with the penile conversion in terms of HPV at the
Yeah, the question is there a concern with HPV with the penile inversion? Yes, there is. So it is skin. It can still be infected with herpes or with HPV. Is there a test? So according to what I read in the transgynecology book, it is less likely for there to be issues with the high risk HPV. It's not good. It's acting against different tissue, and they think that their transmission is lower, but it's not zero. So I think probably best practice is to swab for high risk HPV in that area if there's any concern. As far as screening goes, I'm not sure that there's any screening guidelines at this point. Yes.
You had issues with insurance coverage for, say, like mammograms for trans women, particularly if they maybe haven't undergone legal benefit for change?
So far, no. about insurance coverage for mammograms, and other preventive care for trans women. And no, I have not had any issues with that. Actually, Nevada is fairly good, with their insurance coverage, surprisingly. Other questions? Sure.
I tried to do like the DEXA scan the other day, for transgender women who's been on hormone therapy for 25 plus years, and they wouldn't accept it.
So the comment was having a trans woman who was on hormone therapy for 25 years. And she was 74 and they wouldn't pay for a DEXA scan.
Not under like the.
Regular female.
That's right.
Oh.
Female or male.
I was gonna say, I think it probably just has to do with the wording, because I know I always get Medicare warnings, you know, if I don't use the right code for, you have to use like other disorders of bone metabolism, or like long-term use of yeah, so rather than coding it as like a screening or preventive care, I do it as other disorders of bone metabolism. I've never had any problems getting it covered.
I'll have an issue though.
Oh, we're
There's a regular screening.
so yeah, so it's gonna just depend on the insurance, what they're gonna take. I just keep changing the codes until they all pay for it. I don't know. I just hate playing that game, but unfortunately we're stuck.
Are there any other questions in the room or online? Well, thank you so much. Let's give.
Thank you.